Hi guys, let's see about splenic trauma today. It is the most common organ involved in abdominal trauma and also in blunt abdominal trauma. Based on CECT, we have 5 grades. Grade 1, it is an subcapsular hematoma occupying less than 10% of the surface area or parenchymal laceration of less than 1 centimeter depth or a capsular tear. And grade 2, we have subcapsular hematoma occupying 10 to 50% of the surface area, parenchymal laceration of depth 1 to 3 centimeter or an intraparenchymal hematoma, just less than 5 centimeter. Grade 3, we have a subcapsular hematoma occupying more than 50% of the surface area, parenchymal laceration more than 3 centimeter, and then a ruptured hematoma. In grade 4, we have a parenchymal laceration causing more than 25% devascularization of the spleen or a splenic vascular injury like pseudoaneurysm, which is seen as a decreased attenuation in the delayed phase of CECT imaging, or active bleeding which is confined to the spleen. So it can be a devascularization more than 25% or a splenic vascular injury like pseudoaneurysm or active bleeding which is confined to the spleen. Grade 5 is shattered spleen. There is active bleeding which is beyond the spleen, which is seen as increased attenuation in the delayed phase imaging. Management, EFAST is investigation of choice in patient with who is hemodynamically unstable, and CSCT is done in patient who are stable. For grade 1 and 2 and grade 3 who are stable, we should proceed with conservative management where we monitor the vitals and maintain the hemodynamic state of patient. If it deteriorates, we can proceed with angioembolization if possible. Otherwise, we should proceed with splenic preservative surgeries. Grade 3 unstable or 4 or 5, we should proceed with splenectomy. Now coming to splenectomy, the main indications for splenectomy are trauma, which can be any iatrogenic or accidental trauma, and splenectomy can also be done in portal hypertension and hematological causes like idiopathic thrombocytopenic purpura and hereditary spherocytosis, and oncological causes. Pre-op, we should and specifically in patients with hematological conditions undergoing for splenectomy, we should maintain the coagulation profile to be near normal. Complications out of splenectomy or can be hemorrhage, left basal lobe atelectasis, and there can be thrombocytosis. So prophylactic aspirin should be considered. Pancreatitis and fistula formation can also be seen. And mainly we have opportunistic post-splenectomy infection. This is commonly seen 2 years after the surgery. And so the patient should receive vaccination at least 2 weeks prior to the elective surgery. Pneumococcal